Hello, everyone, and welcome to today's workshop. My name is Daheen Gustav, and I will be providing technical assistance during the workshop. Closed captioning and ASL interpreting are being provided. To view the interpreter, set your screen to gallery view. You can switch between gallery and speaker view in the upper right-hand corner of your screen. To view the captioning, click the CC icon at the bottom of your screen and select Subtitles. All attendee microphones have been muted to avoid background noise and webcams turned off to allow attendees to easily view the interpreters. During the Q&A session, please use the chat box to ask a question. Your question will be read out loud by the session moderator for the presenter to answer. This workshop is being recorded and the recording will be made available for future viewing. It is now my pleasure to turn it over to Dr. Amanda Ricart, Program Specialist at the National Institute on Disability, Independent Living, and Rehabilitation Research. Please go ahead.
Thank you. Hello and welcome to day 2 of the Accessibility of Motherhood, a workshop on disability and pregnancy. My name is Amanda Ricart and I am a project officer at NIDLR. And I'm so grateful that you're here joining us today for this important, underreported and under-recognized topic. The fact that you're here today shows your commitment and your dedication to helping ensure that women with disabilities have healthy pregnancy experiences that are respectful, appropriate, and accessible. And I just want to thank you for dedicating the time to be here, whether it's your first day of the workshop or you were able to join us yesterday as well. On behalf of NIDLR and NICHD, welcome, welcome, welcome. Before we begin, I must thank all of the fabulous colleagues at NIDLR, NICHD, and New Additions for their many invaluable contributions that made this event come to fruition. I am most grateful for all who were involved in this team effort to manifest this workshop. So thank you very much. So for those of you who were here yesterday, it was incredible. Am I right? Don't you agree? The workshop started with Dr. Allison Cernich, the Deputy Director of NICHD, highlighting existing research to emphasize that what we know about the critical need for much more research and policy work to understand and address disability and pregnancy inequities and topics. We also had the exceptional opportunity to hear directly from women with disabilities about the barriers and facilitators impacting their pregnancy experiences, as well as their thoughts on where we most need to focus our current research and policy work. I hope you were able to join us, but it's not a problem if you weren't, because we're going to quickly catch you up to speed. And we're going to catch you up to speed by asking those who were able to attend yesterday's session to tell us in the chat box, what were your biggest takeaways from yesterday's session? So type in the chat box the things that made you go, yesterday, the things you left the workshop thinking about the most. So we're looking for encapsulations of the highlights of the incredible engagement we had yesterday. If you'll type it into the chat box, I will share it with the group. And while we wait for those to come in, as Dr. Cernich noted yesterday, the goal of this 3-day interactive workshop is to identify priority areas of focus and create momentum for the research agenda needed to address inequities in pregnancy outcomes in related healthcare among women with disabilities, especially the inequities experienced by those from underserved and underrepresented populations. Oh, great. Just getting some comments here. Okay. Someone wrote, clinicians have a lot to learn about caring for pregnant women with disabilities. Ami said, how not alone in these experiences I am as a disabled mother of 5 biologically mine children. Anne Craig says, I was surprised that a doctor who is a medical expert was unable to deliver proper care to those with disabilities. And Teresa Cruz says, the need for accessible equipment. Anna says, the lack of training for health professionals when dealing with moms with disabilities. The magnitude and prevalence of provider stereotyping. How amazing the women were that openly shared that we could learn and help to make changes so that healthcare is more accessible. I am 100% behind that, of course. The absurdity that a provider would question a woman's ability to be a mother because they have a disability. Hearing the pregnancy experiences from our panel and their recommendations for providers was very interesting and helpful. How unprepared reproductive health care is for disabled individuals, both pregnant and not pregnant. And from Denise, the injustices that pregnant disabled women face was sad to hear. Ami says also how much disabled birthing people need consideration and inclusion in the midwifery model of care. Heather says the experiences that the panelists had gone through with their pregnancies, the challenges they faced, and what they overcame to become mothers. Many physical and attitudinal barriers to OBGYN care for people with disabilities. Another about the injustices. Michelle points out the importance of family and community support and that it's essential, and how home visiting could have a great impact. And I believe that's all. So I think that this just really highlights how many amazing things we heard yesterday, and really emphasizes the importance of the work that we're talking about today, as well as the need for it. And one more last comment was from Yen, the prevalence of underlying eugenics theories that providers still learn in med school that make them believe that disabled people shouldn't have kids to begin with. Oh, and one more, the complete lack of consideration of partners and supports that pregnant women have. All really, really good points, and really hone in on what the conversation needs to be from here on, and really does a good job of introducing, setting it up for today for the rest of our talk. So thank you for everyone for contributing all of your takeaways. That was really powerful, and I look forward to reading those again. So now it is my great pleasure to introduce Dr. Anjali Forber-Pratt. She recently joined us at Neidler from Vanderbilt University as the new director of Neidler. Her primary interest of area of research expertise is disability identity development. And as a 2-time Paralympian and medalist in the sport of wheelchair racing, Dr. Forber-Pratt has dedicated her life to helping others recognize their potential. Thank you so much for being here, Dr. Forber-Pratt. We are thrilled to have you and look forward to hearing what you have to say.
Thank you so much. I appreciate it. As you heard, my name is Dr. Anjali Fulber-Pratt, and my pronouns are she, her, hers. I am honored to have recently joined the Administration for Community Living to serve as the director of NIDLR, the National Institute of Disability, Independent Living, and Rehabilitation Research. Today, I'm wearing a teal shirt, teal short sleeve shirt, and I'm brown skin with black hair and sporting some really cute white headphones. I tend to wear a lot of different hats, as you heard in that brief opening, depending on the day. Being a Paralympic medalist, an Indian adoptee, a disabled woman of color, a researcher, and an activist. Welcome to day 2 of this co-sponsored event with NIDLR and NIH, the Accessibility of Motherhood, a workshop on disability and pregnancy. We are so thrilled to be able to demonstrate this continued joint commitment to this important work. And a huge shout out and thank you to our NIH and ICHD colleagues, Dr. Allison Cernich, who you heard from yesterday, and also to NIDLR staff, Dr. Amanda Riekert, who, as you just heard here in her opening and from yesterday, her grant portfolio includes the newly funded studies about disability and pregnancy. And also thank you to today's panelists, who you will hear from later on here this morning. And thank you attendees for your willingness to engage and educate each other on such an important topic. Yesterday, you heard from disabled advocates from the community, and today's focus will be on healthcare providers, and tomorrow with a bit more of a focus on research. We need all 3 perspectives and commitments on this topic, and for all to speak and to talk and share among one another, which is why I personally love the structure of this workshop. For so many people with disabilities, in particular women, as well as those who may be biologically female but identify with a different gender, there's a prevailing assumption of being desexualized by society, especially for those with physical or intellectual disability. There's another assumption that disabled individuals are asexual, well documented in the literature, meaning lacking in sexual desire, the ability to engage in sexual expression and or intercourse, let alone be considered desirable by others. There's another subset of assumptions that portray certain individuals with disabilities as perpetual children. These stigmas are also perpetuated by mainstream society, potentially by family members, in addition to healthcare providers. This consistent negativity and feeling of having to defend yourself may also create unnecessary stress and increasing risks during pregnancy. We see all of these reinforced as well in the media. There was recent buzz last month of an intimate sex scene in Showtime's The L Word, Generation Q, featuring Jillian Mercado, where Micah, an Asian American trans man and therapist, and Maribel, a disabled Latina lawyer in a power wheelchair, have an intimate scene, rare both for the trans and disabled community to see such a positive sexual experience in the media. Jillian's words in an interview, she said it was very important for our characters and also for us as human beings to portray the story as humanized as possible and also kind of fill in the gap that part of representation that people are very fearful of because you don't see it. I mean, I never saw it growing up. To have someone like myself who's physically disabled have a sex scene, period. This was groundbreaking and only occurred last month, which indicates just how far we still have to go. Health providers must not shy away from this topic due to these unfounded stigmas. Yet we know that medical providers are not given appropriate training in providing care to people with disabilities in general, which is why workshops like this and funding to support this work is so important. Healthcare providers are often not trained to adapt or modify care for people with disabilities, or those who do have this experience or training may not be located conveniently or nearby. Another taboo topic, and something that still continues to happen to this day, is involuntary sterilization of girls and women with disabilities. It's important for healthcare providers to be aware of this practice and to educate patients and families about the successes of disabled women having healthy relationships, pregnancies, and families. This involuntary sterilization, particularly for women and girls with intellectual disability or other cognitive disabilities, was sanctioned by many states and by the Supreme Court in Buck v. Bell, which, to surprise of many, has still never been formally overturned. This practice, still done, unfortunately, today, is typically done so at the request of a disabled person's parents or guardians who believe that sterilization, hysterectomies, vasectomies, etc., will improve their child's quality of life and or make them easier to care for. Many people have also pointed out that while sterilization can prevent unwanted pregnancy, it does not prevent sexual abuse. The American College of Obstetricians and Gynecologists has urged physicians to consider that in some cases, parents and patients may have conflicting interests, which is another reason why health care providers must be educated on these topics to be able to advocate for patients and allow for informed decision-making rather than decisions based purely on stigma or stereotypes. Furthermore, some ways that we can help to push against these stereotypes is to include women with disabilities accurately represented in informational materials and handouts and online pages, mobile apps, or in patient stories or narratives used. From my own experience, none of this was talked about growing up with my disability. I had to rely on my network of women with disabilities to learn the ins and outs, to learn and witness them going through pregnancy versus deciding to adopt or have a surrogate, and what questions or concerns they had for their medical team. I'm so grateful that I personally have this community, but not all disabled women do. We also know there's added inequities experienced by Black and Brown women when accessing healthcare, not being believed on pain levels, for example, as they go through pregnancy, and other worrisome statistics that can affect healthy pregnancies. This is only exacerbated when you add the layer of disability into the mix, which again is why we need healthcare providers to be allies to and for the disability community, for women with disabilities to help combat these stereotypes and to work together to problem solve and come up with the best plans possible. Regardless of subspecialty, people with disabilities need primary care providers, and OB is a tenet of primary care in this country. Therefore, learning how to best meet the needs of disabled women is imperative. In closing, I just want to name the importance of today's conversation, but also encourage reflection on what's happening as we speak today in history related to these topics. Women with disabilities and clinicians and researchers working together to meet their needs is an important collective voice in the conversation on reproductive justice. Today's conversation will be centered around clinical education, clinical experiences, supporting women with disabilities seeking reproductive health services, successful pregnancies on the journey towards motherhood. And now with that, I'm going to turn things back over to Amanda Riegert.
Thank you, Dr. Forber-Pratt. Those were some really thought-provoking observations, and I hope that everyone takes note and really does reflect on some of the things that Dr. Forber-Pratt has presented with us today. Now, we get to turn it over to the panel members to hear all the amazing things they're going to have to say. Again, you are in for a real treat. These panel members are really an all-star cast of healthcare providers and thoughtful women scientists and practitioners who are out there working with women with disabilities and learning about how we can best improve, make sure that women with disabilities can have healthy pregnancies as well. So the moderator today will be Dr. Christy Kirschner. She is a physiatrist, and she co-founded the Health Resource Center for Women with Disabilities. And this was the first comprehensive health center in the country run by and for women with disabilities. In addition, she has written and worked throughout her career on issues of the unequal access experienced by people with disabilities, including women with disabilities in seeking reproductive health care services. Dr. Tiffany Pankow is also on the panel. She currently is the director of the Deaf Health Lab at the Rochester Institute of Technology Research Center on Culture and Language. Her projects include investigating healthcare access, health literacy, pregnancy experiences, and family planning in the deaf community. And last but not least, we have Dr. Jean Althussen. She is an associate professor and associate dean for research at the University of Virginia School of Nursing. She's a board certified advanced practice family nurse practitioner, and she brings extensive professional nursing experience with a particular interest in the health disparities in maternal and child health. We purposefully invited a mix of healthcare providers wanting to highlight the idea that it's not just obstetricians who are serving the needs of women with disabilities, but really it's a whole host of providers. And as we saw yesterday, this includes ancillary, what we usually consider more ancillary services as well. And so we want to be aware of the importance of addressing the wide range of services that are necessary for healthy pregnancies. With that, I will turn it over to Dr. Kirschner, and I want to thank the panelists for being here today, and we're looking forward to learning from you and having conversations with you. Thank you for being here.
Thank you, Dr. Reichert. I'm so thrilled to be here. This is a topic very near and dear to my heart. First, by way of introduction, I'm a white-skinned woman. I'm against a green background. I'm wearing a salmon-colored sweater jacket, have chin-length, largely gray hair now since I haven't colored it for 18 months, and I wear tortoiseshell glasses. My pronouns are she, her, hers. So I am going to be happy to share my experiences as well as part of this panel. I did run a women's center for about 20 years, most importantly with my colleague, Dr. Judy Panker-Reese, who's a woman with a disability. And we can talk about the model as we get into discussion, some of the lessons learned. I'm going to turn it over now, though, to Dr. Al-Hussein and Dr. Pankos. So we're going to hear first from them, and then I will be back and we will have some question and answer and discussion among the three of us. Dr. Al-Hussein.
Great. Thank you for that introduction, and I'm delighted to be here with all of you today. To describe myself, I'm a white female with shoulder-length brown, dark brown hair, and I'm also wearing tortoiseshell glasses. I have on a blue floral top, and I'm joining you today from my office. So in the background are some closed blinds, a calendar, and a picture of flowers that one of my children made. So I'm going to spend a few minutes talking about healthcare experiences during the perinatal period for persons with disabilities. I'm building on my experiences as a family nurse practitioner caring for persons with disabilities, really in diverse settings over the last 20 years or so, as well as a researcher who has significant interest in improving the care that we provide. And finally, as an educator, in that for the last 10 to 15 years or so, I've taught nursing students, and I have a vested interest in better preparing our future nursing workforce, as I see them as really playing a critical role in assuring equitable care and health outcomes. So I have no conflicts of interest to disclose and do want to acknowledge funding from NICHD, which supports some of the work presented here. Throughout the presentation, I'll use person first and identity first language interchangeably, as I'm careful to assure that my words reflect the preferences of the patients that I've cared for or the research participants that I've worked with. Additionally, when we are talking about the perinatal period, I acknowledge that much of the research is focused on pregnant women and pregnancy outcomes, yet we know that not all pregnant persons are women. And finally, my experiences as a clinician, researcher, and educator are largely limited to the United States. While evident disparities in health outcomes exist across diverse disabilities within the US, we know that in many parts of the world, these disparities are even more striking and in need of a tremendous amount of attention. So we heard yesterday, nearly 61 million Americans have a disability, constituting just over a quarter of the US population. Of that, approximately 12% of US women of childbearing age have some type of disability. In the past, both stigma associated with disability and sexuality, as well as medical factors, including risks of medication use in pregnancy, limited childbearing in women with disabilities. However, with advances in healthcare and an increased recognition of the reproductive rights of persons with disabilities, more persons with disabilities now experience pregnancy. In research that my team has done, including my good colleague, Dr. Rosemary Hughes, we found through analysis of the National Survey for Family Growth that women with disabilities were about as likely to want a baby as compared to women without disabilities. So 61% of women with disabilities versus 60% of women without disabilities. And some of this was discussed yesterday. Yet, when asked about fertility intentions, only 43% of women with disabilities intended to have a child in the future, as compared to more than 50% of women without disability. So significant differences by disability status. And while we don't fully understand the reasons for similar rates of pregnancy wantedness, yet significant differences in pregnancy intention, we do know that women with disability face numerous barriers in accessing and receiving equitable care, really at all levels, the interpersonal level, the provider level, community level, and system levels. And I think our panelists yesterday did a really tremendous job highlighting many of those. So there are substantial barriers at the system or clinical setting level that contribute to disparate outcomes. I've listed some of the more common ones that I've encountered or I've heard from research participants here. We know that a lack of adequate and accessible equipment leads to significant delays in seeking care or even missed appointments, which is particularly important in the context of a pregnancy, as adequacy of prenatal care is a key driver of both pregnancy and infant outcomes. Further, when we're not able to obtain appropriate clinical indices or clinical measures on our patients with disabilities, we're really making clinical decisions without a complete or accurate clinical picture. So things like, lack of accessible parking or lack of automated doors, leading to, one patient recently telling me, how exhausted she was by the time she makes it to the exam room and feeling certain that this is leading to, a falsely elevated blood pressure reading, yet not being given the time, to rest or to catch her breath. I've worked in settings, particularly in rural areas where bathrooms aren't wheelchair accessible. So things like, obtaining a urine specimen, which we do for most pregnant persons at every appointment to check for things like sugar or protein, become quite difficult, if not possible for certain women. A lack of exam tables is really problematic. Some research has found, less than 8% of facilities have accessible exam tables, and that women are rightfully terrified of being dropped. We heard from Jennifer yesterday about her horrifying experience of being dropped twice, within the healthcare setting. So this is a huge problem. Research also suggests that less than 4% of clinical practices have accessible weight scales. Gestational weight gain, both not enough or inadequate and excessive, are risk factors for poor pregnancy and infant outcomes. Yet for many pregnant persons with disabilities, we don't provide the necessary supports to measure weight gain. And then we know that there are significant barriers faced in communication. I've cared for women in labor, back when I was a labor and delivery nurse who didn't have an interpreter present, or in the clinic, they're told that it's going to take too much time. So they rely on a healthcare provider, jotting down notes and going back and forth, knowing full well that they are missing critical information. I've heard from women that they've requested personal interpreters, yet their requests aren't honored, often leading to a complete stranger in the delivery room with them. And this is really, one of the most vulnerable times in their lives. And I should add, that these barriers aren't limited to the birthing person. Rather, we hear from birthing partners as well, from a lack of room for the partner and their chair, to providing one interpreter for the pregnant person and their partner, without acknowledging, that often the partner will go with the newborn to the nursery for a short period after birth, and then leaving the pregnant person alone, without an interpreter, and how torn this makes the partner feel. Another issue, certainly exacerbated during this pandemic, is the use of video remote interpreting, which can be challenging depending on stability of Wi-Fi or how adjustable an exam table is, or even the position that a woman is in during labor. So substantial barriers in the care setting. Time and time again, persons with disabilities experience tremendous stigma, particularly as it relates to their sexual and reproductive health. And we heard that this morning. The quotes listed here are ones that I've heard just in the last year or so. So clearly we have a long way to go. Women face significant opposition to their decisions to become pregnant, with countless stories of women being questioned and judged. Yesterday, I believe it was Erin who talked about feeling judged, when she was attempting to get on an exam table and feeling she had to do it herself, to prove to the healthcare team members, that she was fully capable. I've heard from mothers who refused to lift their babies from the bassinet, in their hospital room while anyone else was in the room because they were afraid that they were being watched, waiting for a mistake to be made. For my patients of color, I've heard the phrase double jeopardy, more than a few times, meaning that they're already scrutinized for being disabled, but then having a baby and being a woman of color, they feel like they're under even more scrutiny. Patronizing experiences, Heather touched on this yesterday with staff saying, are you sure you can do this? Before she finally realized, they were talking about her disability. Similarly, I've heard this and witnessed this where healthcare providers will say to a partner, what an inspiration, they are for sticking with the disabled women. And in my current research, again, with Dr. Hughes, this is a huge barrier to screening for risks like intimate partner violence, where nurses or other healthcare providers won't screen for intimate partner violence, thinking, there's no possibility of that occurring in a relationship where a partner has stuck by a person with a disability. And our research suggests otherwise, that women with disability are at a heightened risk for intimate partner violence, including reproductive coercion in the perinatal period. A lack of knowledge by healthcare providers, I know that was a common theme in the chat this morning, is really a significant barrier to care for women with disabilities. In our study related to unintended pregnancy, nearly 1/3 of women were told that they could not get pregnant due to their disability, with no medical rationale for such claims. Thus, they didn't entertain options to prevent pregnancy, resulting in unintended pregnancies. And I should add that they were often told this, as adolescents when they were visiting healthcare providers to inquire about contraception. I believe yesterday, Jennifer mentioned that was her experience as well. For healthcare providers, there is very little, if any, formal training about disability in our programs. Without explicit training, healthcare providers are likely to continue to view disability as a negative health outcome or an illness, to be prevented. There's been a fair amount of qualitative research from the perspectives of healthcare providers who acknowledge a lack of training and feeling underprepared to care for this population. There was a relatively recent study of over 700 physicians across the US. Only 40% of physicians were very confident about their ability to provide the same quality of care to patients with disability. And nearly 20% strongly agreed that the healthcare system often treats these patients unfairly. Particularly in non-urban settings, women experience significant difficulty in finding providers who are comfortable caring for them. I've heard from countless patients, and I believe Erin mentioned this yesterday, that they're labeled, high risk and not able to be cared for by an OBGYN with no explanation as to what constitutes high risk. And then we know that there is tremendous variability in the supports provided ahead of birth to optimize maternal and infant outcomes. And women report feeling that their specialists are all very siloed with, very little collaboration or consultation between, say, the obstetrician and the rheumatologist, for example. So, I certainly look forward to learning from all of you. But if I had to, name 4 key things that must be enacted to improve outcomes and equity for persons with disability, it would be to immediately address the significant barriers in accessibility faced by many persons with disability. I think we absolutely must build our healthcare workforce's capacity to provide equitable care. Central to this is the expansion of a workforce that better reflects the disability community. We've seen more recently in research aimed at reducing maternal morbidity and mortality that women of color have better outcomes when cared for by providers of color. And I have no reason to believe that the same does not hold true for persons with disability. To make significant progress in eliminating disparities, I think that there's a critical need for improved data and data collection and population-based data sets on diverse disabilities across the lifespan. And I think any research that we conduct related to reproductive health really needs a very purposeful inclusion of social determinants of health, with the continued acknowledgement that many persons with disabilities live at the intersection of multiple marginalized identities, which may in turn result in further inequities. And so with that, I thank you for your time. I have my email and Twitter, and this is one of my New Year's resolutions that I promise I'm going to be more active on Twitter, because I know that is the best way to learn from each and every one of you. And I do have a picture of my university on this last slide, and it's a beautiful fall day. And in the background is Thomas Jefferson's Rotunda. And for any of you that would like to visit Charlottesville, I hope that you will send me an email, and I would love to show you around. So thank you.
Great. Thank you very much. That was a wonderful overview. And I will now turn it over to Dr. Pankow to also share some introductory remarks, and then we'll begin to have some conversation after that. Dr. Pankow.
Hello, everyone. I'm very pleased to be here. I am a white woman with a dark top with a maroon sweater over it. I'm wearing a necklace. My hair is brown and a bit past shoulder length. And my background is green with white paneling at the bottom. My pronouns are she and her. All right, so some of the others in this workshop have different identities that can apply to their work, and I'm the same way. I am a deaf woman. I have received medical training. I have an MD, and I'm also a researcher. And I'm very pleased for the opportunity today to share my perspective as a deaf woman and as a deaf woman doing health research. So I've been working in the realm of public health research since around 2009. In medical school, I faced many barriers, and I noticed other barriers within the system. And from that, I decided that I should shift over to research, that would have a better impact on the world and on improving those barriers in the healthcare system. So I'll talk a lot about the importance of representation, both as a researcher for research participants and for physicians and providers. And I'd like to start by actually pausing and thinking, deaf women's health is really just getting started. So these research issues have often been overlooked or ignored in the same way that women's health issues were often overlooked or ignored until more women became providers. I think the same thing is also true when we look at women's health versus men's health, and then when we look at deaf health. Some of the first publications were in 1994, which was not that long ago. And when we look at the data about how many deaf people with PhDs in STEM fields, in 2010, that's only 10 years ago, 11 years ago, there were only 95 deaf people with PhDs in STEM, which is a very small number. The positive is that that number is growing. In 2017, there were 436 deaf people with PhDs in STEM fields. And that includes many different STEM fields. We don't know exactly how many of them are doing health research, but we know that that number is very small. And of course, we also have to keep in mind intersectionality. So for me as a woman, If I want to focus on women of color, it's not necessarily appropriate for me to do that alone. So I work with a team of other collaborators, or even as part of a larger team where I'm not the lead researcher. But again, there are extremely few deaf researchers of color and almost none in the field of deaf health research specifically. So I like to see the overlap of research in different fields being led by people from that community as part of a multidisciplinary team that includes people with many different identities. And knowledge justice is an issue. Of course, we face this over time. One way of combating that is through participatory research, community-based participatory research, as well as community advisory boards. But again, we need to make sure that we have representation, that we have scientists representing those identities as part of the team as well. When we think about quantitative research, of course, typically that is fairly black and white, but when we develop metrics, when we're analyzing quantitative data, we need people who have that identity and who have that lived experience to be part of that team. And then if we're thinking about qualitative research, when we are interpreting the data that we collect, when we are interpreting what's happening, the researcher's role is important to consider there. So in fact, the researcher with shared identity can consider that shared identity to be a tool that they can use. So my lived experiences cannot be removed from my analysis of the data that I'm collecting, but it should be part of it, and that should be valuable. We should, of course, be careful about bias and about making sure that we are interpreting the data neutrally, but that's a powerful tool that we can use. There's also an issue of data sets, the quality of data that has been collected, and often we don't have as rich data sets about deaf women. There are some great data sets out there on disabled women, but they don't always identify deaf participants in their data. Or they may ask participants if they have trouble hearing, but that's it. And that doesn't necessarily give us enough information about their hearing status, about their deaf identity, whether they use ASL, whether they use spoken English, whether they use both or something else entirely. And so it's also important to differentiate the lived experiences of a culturally deaf person and a person who uses ASL versus someone who has some hearing difficulty. And there's also a question of when a person became deaf. So a person who became deaf prelingually before the age of 3 typically accesses the healthcare system differently than people who became deaf postlingually after the age of 3. So prelingually deaf people are more likely to not use primary care, but instead to go to the emergency department routinely. People who are postlingually deaf who became deaf later in life are more likely to seek primary care services instead. With an interesting exception of mammograms, screening for mammograms. Even prelingually deaf people do get screening for mammograms regularly, we found in the research. But often data sets of people with disabilities don't ask about the age of deafness, so we can't capture that information about prelingually and postlingually deaf identities. And there are some other interesting things to think about here too. So yesterday there was some discussion about cross-disability data sets and including cross-disability data in research. I think that that's a great idea, but I think it's important to be extremely thoughtful about that. And to keep in mind what is causing some of those different data that we're collecting and how society views the disability. So I think that's another interesting discussion that happened yesterday, that not all deaf people identify as being disabled either. And so people who are deaf who do not identify as disabled may not be captured with those data sets. And some research will also combine deaf people and blind people and label them as having a sensory disability. And sometimes that's appropriate. Sometimes it can be difficult to get a large enough N size. If the N is too small, it may seem beneficial to group those two identities together. And that's certainly understandable, but again, we have to be very thoughtful about that. So a deaf and blind person, the way that they navigate the world as a disabled person may not be the same. The language that they use may not be the same. A deaf person may experience more issues with language barriers that a blind person may not experience. They may experience different physical barriers instead. So there are a number of different factors that we have to keep in mind here. Aside from the data, another important facet to keep in mind is electronic health records. So whether deaf patients are labeled as being deaf, whether that's noted in their chart, and whether the word deaf is used or if some type of hearing problem or hearing loss terminology is used instead. And sometimes that depends on the reason for the appointment. The fact that a person is deaf may have an impact on the care that they're seeking, or it may not necessarily. They may be seeking an appointment for another reason. And then the third topic I wanted to mention is representation of healthcare providers. So Jean just mentioned the importance of shared identity between providers and patients, and I fully agree with that. I think there are two different types. There's language concordance, and then there's also disability concordance as well. And researchers have found that if there is concordance between the patient and provider, for example, for language concordance, if both the patient and provider use ASL, then the patient is more likely to use preventative services like getting vaccinated on time and everything else along those lines. So there's one good example of that already. For disability concordance, it's helpful to have that shared experience and that shared understanding. And that's also very important to keep in mind. Physicians and providers should also not worry if they don't have either of those things, if they don't have language concordance or disability identity concordance, but instead for language concordance, if a patient and provider don't use the same language, it's important to bring in an interpreter. Not having enough money or not having enough time is not a good reason. We have the ADA, the Americans with Disabilities Act, and that requires the provision of a sign language interpreter when necessary. And workshops like this are a great start in terms of learning and training for patients and providers, but providers should also not be afraid to ask patients what type of communication they prefer. Patients or providers are healthcare experts. The person with a disability may not be, but the person with a disability is an expert in their own disability, in the way that they navigate their life. And so it's important that there is mutual respect between both of them. And we also have to keep in mind medical mistrust. Many people with disabilities don't necessarily trust the healthcare system. They may often have had oppressive experiences or have felt judged or inaccessible to the healthcare system. So having respect of the provider to the patient is also helpful. And then increased understanding of health literacy, cultural humility, working with the patient on their level and asking them what they need is critical for healthcare providers. There has been some interesting research that has shown in analyzing MDs or DO granting programs and looking at their technical standards of basically what's required to enter medical school. Most of those technical standards do not support the provision of reasonable accommodations for providers in training as intended by the ADA, which is very unfortunate. So there's areas for us to improve there too, because again, training of providers is so important. Having an understanding of cultural humility, especially when you're first meeting a patient who has a different disability that you've never seen before, instead of not knowing how to deal with it, it's important that they know how to provide the patient with the care that they need. So I think that's it. Again, those were the 3 points that I wanted to touch on today. And if you have any questions, if you'd like to contact me, you can find me on Twitter or you can send me an email. If you do a Google search for my name, you'll also probably find my website as well. Please feel free to contact me. Thank you.
Thank you, Dr. Pankhouse. So we've heard from 2 experts in this area with a wonderful remarks calling out the research, the knowledge we have about where the barriers are. And I'm just going to summarize a little bit because I think that we're talking about communication barriers, we're talking about physical barriers, we're talking about knowledge barriers, we're talking about attitudinal barriers. And I think that those barriers are well known to many people with disabilities as they have tried to navigate the healthcare system. Now, I'm going to have us also reflect a little bit on the fact that the ADA was passed in 1990. That was the year I graduated from my residency. And to think about this also from the provider perspective in terms of what are they taught, how are they taught it, what are the structural supports that they have in place? Because in healthcare, I can still tell you a lot of things we're talking about, no accessible tables, no accessible weight scales. Those were all supposed to be fixed after the ADA. But we're still talking about the same problems 32 years later. So I think that the clinical issues, the problems from the patient's perspective, are pretty well refined. I wonder if we could think about this a little bit about where those barriers are in terms of getting the educational system to change and getting the structures of healthcare to change to support the provider and the patient in the delivery of care. So I'm going to invite Dr. Pankow, Dr. Al-Hussein to reflect on their experience and whether they have some insights or thoughts about that.
Sure. So this is Jean, and I'm happy to give an initial thought. And I think Tiffany, touched on this in her last comment when looking at, and I'm not a physician, but she talked about standards, across medical schools where reasonable accommodations may not be required. Well, that's a problem, right? And that's something that I think in a policy level, we all should certainly be engaged in. I do think the lack of knowledge on the part of healthcare providers is a significant issue. Certainly, you do hear and you see positive stories where providers, have said to a patient, I've never had a patient with this type of disability, but we're going to work together, and I'm going to draw on every resource I have to have the best outcomes for both you and your child. But more often than not, I hear from women that they're, quickly referred out to maternal fetal medicine or to another high-risk specialist, or told, to travel very extensive lengths, to the closest big city where they could be better cared for, without an acknowledgement of just how difficult that can be for many women. So I guess it probably brings me back to one of my earlier points, which is we really need to be thinking about social determinants of health when we're trying to reduce disparities and improve equity for this population. I teach in a nursing school. I've taught in a few nursing schools, and I infuse this content in every lecture I give. But I know that that's not the same for everyone. And often you'll hear other faculty talk about, there's no room in the curriculum, or that's not going to be on the boards, and we have to worry about our NCLEX, which is kind of the nursing national test to practice as a registered nurse. They're very worried about kind of teaching to the test, and so that's got to change. I will tell you, I think the future is bright as I sit, in class with this next generation of nurses. In my case, they are far more committed, far more savvy, far more aware of social determinants of health, of reproductive justice than certainly I was, as a young undergraduate. So I'll let Dr. Pankow share her thoughts.
Yeah, absolutely. I agree. And I think that in the new generation, I don't want to be overly optimistic, but I do see that the new generation is more interested in improving their understanding. But at the same time, there are still deeply embedded structural and systematic barriers that are present in the system. And so we need to find a way to improve those barriers somehow. And as you mentioned, the ADA is over 30 years old. And we do need to review that and see how we can apply some of the changes that are mandated by the ADA. I think we also need to bring in more people, and research has showed this, that doulas can provide wonderful support for deaf women. I assume the same might also be true for other women with disabilities. They can take some of that burden off. So as a disabled woman or a deaf woman in a pregnancy situation while they're giving birth, during delivery, they don't want to be thinking about the access barriers that they may be facing during delivery. And so a doula can take some of that weight off of them. I know one big frustration that many people have experienced is feeling like there's a rush of time, that their provider is not giving them appropriate time to spend with the patient to hear their concerns, that they are following a procedural sort of checklist and that's it. And that becomes punitive on the patients. That patients feel like they're taking too much of their provider's time when really it's not their fault. So we also need to ensure that patients have enough time to also develop their health literacy, to not only rely on the providers because their time is limited, but also to make sure that they can have the health literacy to get the information that they need outside of those physician appointments as well. So I think there are many different layers to this question that we have to think about, certainly.
Thank you. I think that these comments are really helpful because many of us who teach actively now, I can tell you, have that very positive feeling that, you know, we've got students who get it, they care about it, they want to learn it. I also think that, you know, if you look at the ADA, the law isn't really enough to solve this problem. The law is one lever that we have. But I think in terms of looking at the Institute of Medicine quality metrics, you know, is our healthcare system patient-centered? Is it safe? Is it timely? Is it equitable? Is it, you know, efficient? These are the kind of healthcare systems metrics that I think we want to be aiming towards. So trying to figure out where those bottlenecks have been. So thinking about, you know, the healthcare education system. You know, I also come from a background in disability studies, you know, where we talk about medical model of disability and social model of disability. And my medical school back in the 80s, we really didn't talk about disability at all, but there was some hidden curriculum regarding the medical model. And I think that's what many of us are still talking about when we talk about eugenics, or we talk about the goals of medicine regarding disability, or why do you need to go to a high-risk provider if you're a woman with disability who happens to be pregnant. So sort of taking that step back and critiquing what are we being taught and where are we being taught it is really important. I'm going to invite in a minute our people who are participating remotely to also feel free to self-identify if they come from OBGYN, if they come from the nurse midwife, nurse practitioner, family medicine background, because in my experience, those are the areas where you think of reproductive healthcare services occurring, but it's also been somewhat difficult to get them to fully engage. So we'll open that up for discussion in a few minutes, because a lot of what we're talking about requires a team, and it requires also interprofessionals in terms of our model of care. So I want to get back to this issue of concordance, because I think that Dr. Pankow, you raised the question of concordance, as did Dr. Alhuson. And, you know, we know that there aren't very many health practitioners who also happen to have disabilities. We know that concordance makes a difference when it comes to race and ethnicity. Do you have any direct experience in terms of health practitioners with disabilities, in terms of what difference that can make in the provision of reproductive health care services? And I'll just open it to either of you.
Okay, sure. Absolutely. So I am just one person, but I can share that I had many frustrating experiences, and that's part of the reason why I shifted paths And I know that I'm not the only one. I know that other deaf and disabled practitioners have faced the same types of issues in the system. The education system is not fully welcoming. I mean, again, we can just look at the technical standards and recognize that the technical standards are just one example that do not include education on deafness or disability. So that's something that we can work on. At RIT, for example, we do have programs to support undergraduate and graduate students in research careers who are interested in biomedical science research careers and interested in pursuing a PhD. We have support now for that. And we are now working on expanding that for others in the healthcare field. That is a topic that's extremely important to me, that we provide those wraparound training programs for deaf people who are interested in becoming healthcare practitioners. And at some point in the future, I know that we don't always have the option for deaf patients, deaf or disabled patients, to find practitioners with the same disability identity as them. That's not always possible or realistic. And so that's where cultural humility training comes in. I think that's very important. And I'll turn it over to Dr. Alhusen.
Thank you. Yeah, this is Jean. So, I think concordance is absolutely critical in both health professions and research. And Dr. Penko has beautifully laid out why this is so. I think increasingly, particularly in research, there's really an expectation that if you're researching aspects of disability, you are including persons with disability in that work. And I know on projects that I've worked on, we've been explicit about that. And I've benefited tremendously from the experience and expertise of several individuals on this call. With regards to health professions, unequivocally, we must do better. And I feel certain outcomes would be improved if there was concordance. A lack of diversity in the physician and nursing workforce and other disciplines, social work, psychology, you name it, has been the subject of numerous studies where we know that levels of women, racial and ethnic minorities, sexual and gender minorities, and people with disabilities are lower than predicted from their numbers in the general population. I apologize that I don't have recent data, but as of 8 years or so ago, I believe that less than 4% or so of medical and nursing students reported a disability. We know that there's incomplete data, underreporting, and differences in methodology that may underestimate true prevalence, but suffice it to say, we're nowhere where we need to be. In the various settings where I've taught, both public and private universities, I've not seen great attempts at recruitment of these students. I think we need to be explicit in defining responsibility for accommodations and providing those accommodations, to include personal and professional networks, as well as mentorship. So, I'm not aware of any programs have done this remarkably well, and I hope that members of the audience may be so. I did actually recently try to write a grant to do this in nursing. It wasn't funded. But I'm going to take that feedback and I'm going to continue trying because I really think that this is so critical. I mean, we've seen it again in trying to reduce the extreme disparities in maternal morbidity and mortality for women of color. We've seen that it works. And so why we haven't done this as much as we need to do in my discipline is frustrating.
Yeah. So, I think, again, when you look at efforts that are currently going on, there are some hopeful sort of ongoing efforts with the health services listserv for students with disabilities taking place. There's a monthly seminar with Stanford students with disabilities and an attempt to mentor students and pair them with health practitioners with disabilities. So I think some of that work is beginning to offer some hope that we can help have better pathway programs. There's work on the technical standards, at least in medicine, I think in nursing as well. But to keep those from being a barrier, Tiffany is absolutely a critically important issue. But then looking at the content of what people are also being taught in their training programs. And it's absolutely a fact, there's a lot to learn. So we have to also work on information management, teaching people to understand what they don't know, and then where to get the consults and the referrals to get the information that's needed. So very difficult, thorny problem. But before we wrap up sort of this moderated section, I also want to mention.
Could I add? This is Tiffany speaking. Could I add?
Mhm.
If I could just add very quickly, I wanted to make a couple points here. First is that I think, and I'm only speaking for deaf people, I'm not sure about the disability community, but one of the issues is that we often use the ADA specifically as a reactive measure. So when we face an issue, then we have to mention that the ADA requires this and that, and we shouldn't need to do that. We shouldn't need to become combative in that way or use the ADA just to be reactionary. We should be able to use the ADA proactively instead of running into barriers and having that extra hurdle of having to overcome some barrier. We should be more proactive in that way. The University of Rochester Medical School does have an annual event called Deaf Strong Hospital, and that's a role reversal exercise for first-year medical students. And it's a really good experience for them. They have that experience for the very first time of just a very small experience of what it's like to be a person in an environment entering a medical system where there is no interpreters. The doctors and providers don't use the same language that they do. Communication doesn't happen effectively. And at the end, they're given an interpreter so that they're able to have access to that communication. And they realize why language concordance is so important. They realize some of the tenets of cultural humility and so on. So I think to add that program to cover other types of disabilities, other issues that may be faced in the healthcare system, that causes the medical students to feel something and to really keep that in mind through that experience. So I just wanted to share that one way of training future providers.
Thank you. I think that having model curriculum that can easily be adopted, in training programs would help a great deal. Because disability also, if we're talking about, sensory disabilities, physical disabilities, cognitive disabilities, psychiatric learning, intellectual and developmental, these are all areas that have different issues and materials that students need to be taught to understand how to care for populations with these characteristics. So I think that we're talking about a pretty daunting ask, but there are ways to, again, introduce this, particularly when we have model curriculum to Tiffany, like you're describing, things that actually work, that maybe have some data behind their use. If I were to wrap up the panel by asking the two of you to reflect on if you could wave a magic wand and, identify the top 3 priorities that need to change in order to make healthcare accessible for women with reproductive healthcare needs, what would be the top 3 things that you would each target?
Sure. So this is Jean, and I'll take a stab. And I would just say, removing stigma. I think that's a huge problem. Women with disabilities experience it at so many different touch points in the healthcare system, from even trying to find a healthcare provider to accessing the supports within the system to receiving care. And so I think until every person is treated with the same level of compassion, dignity, and respect, we're going to continue to have health disparities. I've said it a few times, but I'll say it again. There's a real lack of knowledge on the part of healthcare providers, and I think that's a significant issue that we must do better in. And then Tiffany talked at length about this, but the gaps in research. Until we have the population-based data sets that adequately reflect, the very populations that we're trying to improve care for, we are not going to make the progress that we could in reducing these inequities. So I would say, stigma, education, and research.
Great. Dr. Panka, what else would you add?
Well, it's a good question, a bit daunting. I think my 3 top priorities would be increased knowledge in general for both researchers and healthcare providers, and health literacy. So seeing a provider is just one aspect of the healthcare experience, and it's really a very small aspect of a patient's healthcare experience. So increasing health literacy is critical. That would be the first one. Second is cultural humility. And again, that would apply to anyone with disabilities, even people without disabilities as well. Be humble, respect, and listen to your patient. That's key. And then the third priority, I had to think pretty hard about this one, but I think the third priority would be increased time and or increased staff. So that could be, as I mentioned, doulas, that could be other specialists who can talk with patients just about contraceptive use, for example. There could be many different models, but we know that the healthcare provider may not have time to do everything. And so to do better, we can add extra time or extra resources.
Wonderful. Excellent list. I'm going to turn it back to Dr. Reichert to help us with some of the audience questions.
Thank you. Thank you for all those excellent comments and thoughtful preparations. Now we'd like to open the floor to all of the participants. If you will, put your questions in the chat. I will read them out loud for the panel members to respond to. Also, feel free to put in some comments that you think, what you're thinking about the things you've heard today or yesterday, and the things that you think are most pressing in this area for research and policy. While we wait for some questions or comments to come in, I just wanted to note that I thought it was really interesting to hear Jean, and I think you in particular, but everybody really echoed from the provider perspective what the women yesterday were saying on the panel. Women with disabilities were saying was their experience, and I think that's really powerful. That there's so much overlap. Okay, so we got some questions from Ami. Since we can only message to hosts, okay, she asked me to repeat the name with the invitation to comment so people who didn't know who was making the offer know who to send the messages to. Okay, thank you for that. Linda Longbalil says, do you think it is more effective to teach medical and nursing students about caring for people with disabilities generally, or is it better to focus on sexual and reproductive health, etc.?
So this is Jean. I hope I can choose all that apply, and I would say both. And I don't think we should have separate curriculum on, a disability module, if you will, or a course specific to disability. I think it needs to be infused. So I'm speaking specific to nursing, and maybe Dr. Panko can speak to medicine. But I think it needs to be infused in every course we teach, and not just in the acute care setting, but, in the community, what sort of supports are these individuals needing? I touched on this a little bit in my remarks that in a study that Dr. Hughes and I did, 30% of these women, and we heard this yesterday, were told largely by their pediatricians, or if they saw adolescent medicine, which was rare, that they couldn't get pregnant. And so that kind of halted any further discussions on birth control or sexual and reproductive health. But more commonly than that, we hear from women that they just skip that whole section. And I've seen it in my own EMR. I'll go in to see a patient with disability, and I can look back at, the last 4 kind of visits, and those questions are just skipped. And so I'd like not to make it an either an or, but a both for sure.
Dr. Panka?
Yeah, I absolutely agree. I think it would be wonderful if that could be naturally interwoven with everything else that's being covered in the curriculum, just as with any other topic. So, for example, often we see dermatological issues and we see pictures that are interspersed throughout the curriculum. And those pictures are often based on white people with light skin tones only. And so now there's a push to integrate more different skin tones and darker skin tones as well. And so I think something similar, just to have that topic interwoven throughout the curriculum naturally so that it shows up in many different situations.
I'm going to jump in here too, because when I started back in the 90s, disability at Northwestern was taught as part of the rehab elective. So medical students actually got exposure because they all rotated through the Rehab Institute of Chicago, but it was in the context of rehab. So it was that specialty out there. People with disabilities are going to touch every aspect of medicine. So in some ways it was a very rarefied view of disability, specifically regarding what rehab services have to offer. So I agree totally that this needs to be integrated. You know, this is a very common issue in the healthcare system, and it shouldn't be segregated as this group of patients out there. So, you know, whether it's the WHO ICF model or the biopsychoecological model of, you know, disability, we need to teach a model that's very broad, that that crosses all the different kinds of disabilities, so students can start to think about those social determinants, the environment, you know, what's medical or biologic, and begin to parse those things.
Excellent, thank you. Any other questions? Yesterday we had lots and lots, and today everyone's being quiet.
Amanda,
Yeah.
this is Jean. I would love if there are people on the call who have examples of programs that have been successful in increasing enrollment of students with disabilities or other types of programs. If they could share those experiences, I would benefit from that.
That's an excellent question. Thank you. Anyone out there have some great experience in that area?
Well, it sounds like it might be a good study for Dr. Penko and I to do, and maybe you to fund.
I've got a couple questions that came to me directly, and I don't know, I can just anonymously ask the questions if you would like, Amanda.
Sure, go ahead.
Yeah, so we've got a question, a woman with a disability who happens to have cerebral palsy wants to have a baby. What are some tips you have to find the best healthcare providers for her? I would always say start with your community. Go to the Independent Living Center, talk to, you know, women with similar disabilities about their experiences. I think that word of mouth is still one of the best ways to try to find disability competent professionals who can help you navigate that that journey. In our clinic that I used to be a part of from 91 to 2009, we always emphasize preconceptual counseling. So if you're thinking you want to have a baby, try to find somebody to first of all have that conversation with. What will the pregnancy be like? What kind of, you know, supports, what kind of team will you need to have around you? So starting out with somebody who is open to working as a partner. And I always felt like if you had an OBGYN who didn't know a lot, but they were very open and wanted to learn, you could bring in a disability expert in the condition and you could start building your team from there. You might need to have, a PT or an OT or an anesthesiologist or whatnot. So a lot of it starts with the attitude and willingness, and then building a team around it. But word of mouth is always a good way to start. Jean or Tiffany, any other thoughts?
No, I would agree. And what I hear from patients and research participants is exactly what you said, which is they turn to their community, Facebook, other types of support groups for those types of recommendations. I do think if it were me, I would certainly want to, meet that person and interview he, she, or them to make sure it was a good fit, because, this is just so important. When you're talking about things like, any special anesthesia considerations, or if there are concerns that for whatever reason, the infant might have to go to the NICU, all of those orientations, if you will, should happen during pregnancy and not, at the time that a pregnant person shows up in active labor. And that's often what we see. And then as a healthcare team, we're scrambling to provide the necessary supports when, as Dr. Panko mentioned, we need to be more proactive than reactive.
Anything else you want to add, Dr. Panko? No.
I can't think of very much to add. No, I think everyone else covered it.
Well, and I think I'm going to build a little bit on what Jean said, because I think this understanding that you want to be prepared, you don't want to be scrambling at the end to try to put together the resources in the team or having a plan in place. If you're going to need interpreters, you want that discussed ahead of time, so the interpreters are there when you need them, and you have the right number of interpreters, Tiffany, from mom and dad, or, so I think that preparation is really key. And that can also be very true when you're thinking about parenting. So we would always try to get our women with disabilities in to work with the OT around parenting support before, they had the baby, because you might want to purchase particular equipment, or you might want to practice with models, or decide what you might need support with in terms of the parenting skills. With anesthesia, you don't want to wait to the last minute to try to have a plan for delivery, labor and delivery. You may want to see the anesthesiologist for a consultation also very much before anticipating those situations. So I think that preparation and having your team in place is also just really important in trying to make sure that the lead on the team understands the importance of communication with the other providers. There was a question from somebody also about doulas, and I don't know much about doula training, but interested in where would you get training? Does anyone know about training for doulas to help be that bridge that we're talking about between the OBGYN and the pregnant patient?
Tiffany, do you want to start? Or I'm happy to.
I am not very familiar with doula training either. I do know that research has shown the benefit of it, and that research findings have supported more use of doulas and more training for doulas.
Yeah, absolutely. Tiffany is right. There, particularly for women of color, we are seeing improved outcomes because doulas are often providing support throughout the whole perinatal period. So not just at the time of birth, but during pregnancy and in the postpartum period. And there is really kind of a variety of training and certifications, if you will, with some kind of like national, where you take a certification exam, to more of the kind of community healthcare worker model, if you will. When I've talked to patients or worked with doulas at my healthcare system, they are welcomed. They are seen as invaluable supports, and they're really seen as a member of the healthcare team. And for many women, and particularly those who are more marginalized, they really can be, an extra voice, if you will, which they shouldn't have to, but they often act as an extra voice, as you're progressing through pregnancy and the postpartum period.
If I could just quickly add to that, not directly about doula, but in terms of additional support staff, I'm thinking about lactation consultants as well.
Mhm.
And that is very necessary. I know that there are some deaf and hard of hearing doulas. That number is increasing, which is great. But there are very, very few deaf and hard of hearing lactation consultants. And part of the reason for that is that the training programs that are offered are not fully accessible. So I'm currently part of a group that's working to fix that problem right now. But that is another additional example of a support staff where it would be great to have language and disability concordance as well.
And the OT can still be a very important part of that team, because the OT may be able to offer guidance in terms of positioning strategies or equipment that could help in terms of breastfeeding. So in my work, we used to have the lactation consultant and the OT also communicating with each other and perhaps meeting with the woman together.
We do have one more question in the chat, and I'm not sure if everyone can see what's in the chat that I've been trying to put through. I'll find out, but basically people are putting a bunch of resources, and we'll be sure to share those after the workshop today or tomorrow. So the last question, since we're almost out of time, from Janice is, I have a pregnant mom with a childhood brain injury resulting in loss of function in her dominant hand without post-rehab gains. She's afraid her family and medical specialists will decide she is unable to care for her newborn. I cannot find any service or strategy for assisting a mother in that situation. No doula programs are quite appropriate and few are available. Anyone have a response to that?
Through the Looking Glass in California is a very important resource in terms of, again, thinking about parenting supports for people with disabilities. Finding an OT that's willing to work with the woman could be a very important resource. We're talking about parenting capacity, and you can be a mother if you can direct the care of your child. You don't have to physically be able to do everything yourself, but you may be able to do a lot more than you think with the right equipment and strategies that can be learned. So I think, starting to hook in through the Looking Glass is a national resource, and they do have a lot of information and equipment, but to also find out if they know any resources closer to where the woman lives.
Excellent. We will, as I mentioned, we'll be sure to share these resources and the ones that have come through the chat also. In addition, we'll be writing up a summary report of the whole workshop that we'll share with you. As I believe Sadie mentioned, or Daheen, I can't remember, this is being recorded, and so you'll be able to share it with other people or watch it again. I want to thank our panelists again for being here. This was an excellent discussion, and I wish we could keep talking all day because I know we've just touched the tip of the iceberg at best, and I really would love to be able to pick your brains over a long period of time. But I think it's great that we have gotten the conversation started and reminding people of the importance of this topic. And I appreciate you being here to share your thoughts. I also want to thank everyone for attending today, and I hope that you can join us again tomorrow. It will be another engaging conversation and with researchers. And I want you to, I know that several people have written to me asking if there's going to be any discussion about women with intellectual and developmental disabilities. And tomorrow we'll have a lot of information of focus on that. So if that's what you're most interested in, you'll definitely want to tune in tomorrow. Thank you once again for being here, and I will turn it over to Sadie.
Thank you, Amanda, and thank you everyone for attending day 2 of the Accessibility of Motherhood, a workshop on disability and pregnancy. The topic for tomorrow's workshop is disability and pregnancy researchers. And this concludes today's event, and you may now log off at any time. Thank you.